Hi, everybody. This is Jeff Cantor. I'd like to welcome you to your Freedom Hub's presentation of the free market cash patient. As I said, I'm your host, Jeff Cantor, along with Charles Frohman. We do urge you to subscribe to these on an ongoing basis. They are every week at this time at yourfreedomhub.com/cash patient. And also, had to stumble over that. And then also, this is sponsored by yourfreedomhub.com, where we're definitely uniting all these freedom activists and all the entrepreneurs that are out there to try to make this a better place for all of us to live. And so we're excited to have you be a part of that movement. Now, also, just so you're aware, we are going to have a great guest for tonight. But before we do, let me just again show you where all these areas exist. So if you go to register, you'll land at our landing page here and be able to enter your information, get notices on a regular basis. All these recordings are released on a weekly basis over the weekend, so you'll see them come Monday. So tonight's will be posted on Monday. And then also you'll want to come to our sponsor to see some of the other areas and things that are happening that will impact your world, as it were. So that's our little outside information. And on that note, let's talk about what we're going to discuss tonight. So Charles, if you will do the honors here.
Sure, Jeff, and welcome, Janis.
Thank you.
As Jeff and I, market our Forbes featured cash patient maker, and now with this award-winning WOW app, we market to a lot of different target groups and cohorts. And through LinkedIn, and somehow we met Janis Powers, who is a longtime consultant for large health systems at Deloitte. And she recently started Longitudinal Healthcare as the founder and CEO with this really neat direct-to-consumer app, Know Thyself. And she is an Amazon best-selling author with a healthcare book. And you can see it right there on that website that Jeff is showing. And so we have a lot of guests every week that really shows you what can happen when we move to a real market that rewards patients and the best medical providers around cash prices, which is the secret sauce. So we've heard of direct primary care. So many doctors, sick of the third-party dominated system, are trying to attract patients on a cash basis or a monthly membership basis. And we've also heard about the importance of preventive care, but we haven't heard of direct preventive care. Before tonight's show, we heard from our friend Bob Staubel about, per order musculoskeletal therapy. So there are some direct to consumer innovations out there, but this is kind of a new one for me. So I'm excited to hear Janis talk about her disruption in the healthcare market, Jeff.
Me as well, because it's such an interesting set of words that you've chosen there, and so I'm keen to see what that would look like, because that's always the missing element, is why are we letting all these things happen and why are we not preventing a bunch of stuff?
Right.
So Janis, I'm going to give you control here, and if you'll take the screen and begin to share your material.
Okay, I'm going to talk a bit first, so I don't know if you can see me talking.
We can. Because
I'm seeing you, Jeff. Okay. Well, first of all, I want to thank you and Charles for having me on the show. This is I'm late to this party, but we've been advocating for the same things, and it's really great to sort of start to dovetail and be able to share all these ideas together. And I'm grateful for everybody on the call, on the webinar, for taking the time tonight. Please, I'd love to link in with you, connect with me. I've got about 4 websites, so there's plenty of ways to reach me through Twitter, LinkedIn, whatever it may be. I'd love to follow on with what you're doing and hear about what's going on. I really enjoyed last week's show about the WOW app, which was really, really comprehensive. And I think a lot of what I would like to do is very analogous to that, but our approach is really different. So we're looking at coming into the market through sort of the front end, which is preventive care. And before I get into talking about the app, I'd like to give you a little background about me, and I've got some slides, but I'm also really looking forward to some questions. So Let me share my screen here and pull up my presentation. Okay, so we are Longitudinal Healthcare. I am the founder and CEO of this company, and it's not letting me show the whole thing. Okay, there we go. Okay, so our tagline is we're taking preventive care out of the doctor's office and bringing it directly to you. So this is an early stage pre-revenue company. I am in the midst right now of actually developing this app with a tech company, which is really, really fun. But we are not at market yet. But I have been at this for about a year to try and figure out how to, bring this company to a revenue phase in something that's actually sellable, which if you're an entrepreneur is one of the hardest things. Here's a little background on me. As Charles mentioned, I started with Deloitte. I started in 1995. I actually have a degree in architecture from Yale, and I have an MBA and a master's in architecture from Michigan. And I joined Deloitte in the 90s when all the hospitals were merging. So that's how I got the architecture degree in, because it was facilities planning. And when you're doing hospital mergers, the way we were, it was a strategy job, a lot of operations, a lot of finance, and I worked all over the country. So the largest for-profit health system, the largest not-for-profit health system, the largest integrated delivery system, all over the country. And so I know hospital operations inside and out. And then I've spent about the last 6 years working in the ambulatory surgery center space, which really got me hooked on this direct-to-provider payment model, which I'll get to in a bit. But I'm coming at this sort of disruption in healthcare because I was frustrated with the power of payers. So what I would see in all the work I was doing, and I've been a career consultant, I've never worked for a hospital, I'm not a doctor, I've never worked for the government, so I've only been consulting, so I really don't have any allegiance to any established organization. I've never worked for an insurer. Increasingly, I would hear that doctors and providers were their practice patterns depended on who was paying. And I think we all know Medicare is the largest single payer in America. They dictate the terms of service for most of what goes on in hospitals, because most hospital patients are Medicare patients. And because they're so powerful, everybody else has to sort of follow on, which is really frustrating. I mean, obviously we've had these problems with the fee-for-service environment being a function of this, how the payment system is structured. But I think it really hit home for me maybe about 5 years ago when I was working for a rural health clinic in Texas. And, it's a rural health clinic, so the payer is going to be Medicaid. They had a lot of, you can't even call it self-pay. They just had to provide the care for free, charity care. And they had a lot of grants. And this is sort of a misnomer where people would think, oh, the clinic got an $11 million grant, they're flush with cash. But that $11 million comes with strings. And in this case, it was a women's clinic, and the grant was for, they wanted to improve, discussions about birth control and family planning. And depending on who came in, the doctor said to me, I don't know what I'm supposed to say. I have to change what I say based on the payer. So if it was if Medicare was paying, then this woman wouldn't have these conversations, because this is not a woman of childbearing years. If it was a young woman, like a 16-year-old girl that came in to get contraception, they try and sit this girl down to have this 10-minute conversation so they could get their grant money, which nobody wants that. And then they try and include it in all these other conversations. It was just ridiculous. I mean, so I have, really, that frustration drove me to take about 3 or 4 years to write Healthcare Meet the American Dream. And I think I don't want to spend too much time telling you how messed up the system is. We already know that. The intent of the book was to say, the first half is, here's my view on what's wrong. And then the second half was more of, what's a totally new idea about how to fix it. And once I finished the book, I realized that I pretty much had to quit everything and go try and do this, because if I didn't, then I would sort of regret it for the rest of my life. So the company Longitudinal Healthcare and this Preventive Care app has all come out of this idea from the book, which I'll talk about a bit more. But to let you know, I also have a podcast. We just published the 20th episode yesterday. It's me talking for 20 minutes, so I don't interview people because you really can't get into too much nitty gritty. And I figured I have plenty to say myself. And they're really different views on the healthcare system. And I take politics. So this particular one was about the Iowa caucuses and everything that kind of went wrong there, and then compared that to things that are wrong in the healthcare system. So it's just another way of talking about things and giving alternative perspectives. So I encourage you to sign up for that if you're interested in podcasts. So that's a bit of background about me. I wanted to give a little bit of a historical perspective and what I think is lost in the system. And, you know, this all gets back to why preventive care is so important. I think that we have really lost personal accountability in healthcare. So when I was writing Healthcare Meet the American Dream, this book, Manly Health and Training, which I have right here, was sort of rediscovered. So basically, somebody was doing research on Walt Whitman and uncovered all these papers that had been published in the 1850s. And he was paid to write some stuff about health and healthy behavior. And so this was packaged up into a book, and it came out, you know, maybe about 10 years ago. So this is pre-Civil War. And it was basically like, there's nothing, like you're on your own. So there was a real element of civic responsibility for health, because if you had to ask someone for help, then it was a drain on somebody else. And, you know, you couldn't fall back on anything. So he wrote all about these things that we're now sort of rediscovering that are really important. And it's just wild to read this book. There's all these sketches in the book about exercise. He talks about wearing, you know, comfortable shoes. He talks about basically the paleo diet, which is, you know, somewhat analogous to the Mediterranean diet, which is supposed to be, you know, one of the most healthful diets there is. And this is, you know, all the way back 160 years ago. And in our app, we've got 6 modules in the app, and I'll talk a bit more about them. But one of the modules is called Rocket Science. And basically the idea is that it isn't too hard to do the things that you need to do to be healthy. And the module asks you questions about 3 areas: exercise, your diet, and how much you sleep. And the majority of Americans fail to satisfy the clinical recommendations for, you know, any one of those, let alone all 3 of them. But whenever you get a health assessment, it almost will always tell you to eat better, to exercise more, and to sleep. So it is not rocket science. In fact, Walt Whitman said it 160 years ago. So it was, you know, a really impactful book. We're now almost completely at the other end of the spectrum, where instead of us having to be in control of everything, we're going to hand it over to the government. I don't think we're going to ever get, you know, a full Medicare for all plan, but it is really popular, and one can understand why. It sounds simple. I mean, I'm not a fan of it myself. There's a whole chapter in the book about why we're never going to have it. But I think the thing that we have to understand is that it's not like this is some new phenomenon where, you know, social democrats are now saying that, you know, we need this government-centered plan. For decades, politicians, both, you know, Democrats and Republicans, have been implementing health legislation, and they've been building up sort of the apparatus because people like to vote for it. And I think one of the genius things that Bernie Sanders has done is to take this idea of a single payer system and rebrand it as Medicare for all. Because what that says is, first of all, seniors love Medicare. Trump's latest budget pretty much doesn't touch Medicare because he knows that, you know, a lot of the voting constituency are older Americans who are on Medicare. So Medicare never gets cut, although apparently he's going to talk about it, but it's a difficult thing to do. By saying I'm going to have Medicare for all, it takes the younger generation who, you know, is this sort of okay boomer. They're sort of somewhat resentful that they're not going to have access to these entitlements, and says, you're going to get it too. So there is this, you know, branding element, which I think is fascinating. I just worry because when you read about this, people are so desperate for something else that they're willing to turn to that. And I don't want that to happen. I would prefer that the free market addresses these challenges and we bring solutions that the public, by their purchasing power and by their choices, have decided that they want. Because the second we hand healthcare over to the government, it goes into a swinging pendulum where we're so polarized as a nation that, if you're on one side, then the other side's going to try and undo everything that's done. And then the other side's going to undo and then you just get nowhere, which is why, it's been 10 years since the ACA has come out, having, spent time with providers, they're sort of catatonic. And I'd say over the last 5 years, hospitals and stuff have become predatory with their pricing because there's so much frustration on their side. We're obviously all at the boiling point. So what I would like to do ultimately is just replace the whole system. So our big language is, we're on a mission to eliminate health insurance, and this preventive care is sort of the beginning of all that. What I believe is that the timing for this could not be better. Like 10 years ago, we couldn't even contemplate this idea because genetic testing has really exploded. I mean, we've just mapped the genome, and it hasn't even been 20 years. So we're like barely scratching the surface on understanding the power of genetic testing. And I think people overestimate the power and don't quite understand it yet. There's 10 new tests that come out every day. But it's completely amazing. There's so much to learn about that. We've got these great new predictive analytics tools that we didn't have 10, 15 years ago. We are starting to appreciate that it's these external determinants of health, a la, rocket science, what, Walt Whitman was saying, along with socioeconomic factors that, this is the majority of what determines your health outcomes. It's not just getting people on insurance. We also have all these new drugs and therapies. I think, when people talk about the cost of care, I find it fascinating because the cost of your healthcare is a function of what drugs and therapies there are on the market. So if you were to say to yourself, like 50 years ago, you compare a person who's blind with a person who has cancer. And 50 years ago, the person who was blind was more of a drag on the system because there were all the social costs of taking care of them because they were blind. And the person who had cancer, they died. Now, amazingly, we've really started to break up what cancer is. In fact, we have a whole module just devoted to cancer because we now know that, it's like each kind of cancer is its own separate disease. There are $750,000 therapies for cancer, that can cure you for certain things. So now those folks are more of a burden on society. So it's just it's something we've really got to get our heads around and figure out how to ration that. I think that's one of the biggest challenges we're going to have. It's certainly the biggest challenge for Medicare. And of course, the system is doesn't work well. It's sort of crashing down. So because of that, we should be able to take the insurance pool that we have and break it up because it's just too big. Like right now, there's 330 million Americans. We're arguably the most diverse nation in the world, especially for our size. When you put all these people together in a pool and try and manage it, you can't titrate. You can't, everybody gets watered down. Sorry about that, that's my phone. And you can't provide the care that certain people need. And I think there's this sort of spectrum of people who are, sort of born with pretty good genes. They really take good care of themselves. They're sort of on one end. And then you've got this other group of folks who don't have really great genes. They may have been born into, poor socioeconomic situation. That's really tough. And then there's all these people in the middle. And if you look at sort of what I'm calling this outmoded health insurance model, like everybody's in the pool and some people could be really sick. They could be really healthy. We don't know. With the Affordable Care Act, one of the most popular aspects of the ACA is that people can get access to insurance regardless of their pre-existing conditions. And that gives people who really need healthcare insurance, like access to it. It's kind of crazy to lock those people out. The negative of that is that there's really no incentive to be well because it just, you're going to get covered. And that's a real accountability problem. And when 70% of the American population is overweight or obese, and we're tracking to half the population being obese, I think by 2050, I mean, it's out of control as far as the folks who could be healthy and aren't. So I want to shift more into this model where we can identify better who is really sick and can't help it, identify who's really healthy and let them go do their thing. And then take the middle section and say, let's get you healthy. Let's figure out what we can do before it's too late, which gets back to preventive care, to help you help yourself and live a healthier life and lower your costs. So that's sort of the backdrop on the concepts in the longitudinal healthcare plan and the company and what was discussed in the book. So this is sort of an overview, and this is straight out of the book, because I'm a consultant. I have to, have these little modules and stuff like that. But, short story, in the future, this is sort of a futuristic idea. I think that it would be great if we had basically a product called a longitudinal healthcare plan, and companies like my company would basically replace insurance companies. We'd be your fiduciary partner. We'd be like a bank, and with a healthcare like overlay on top. And we would do sort of a workup on our customers, and they come, we do a genetic analysis, and a lot of this stuff is already out there. It's just how this would get packaged. And I think this concept right now is, the market's not quite ready for it, but it's ready for parts of it. And I think this is very analogous to what you're trying to do with the WOW app from last week, which is, I love that. But we would take your genetics into account. We'd do a physical exam, obviously take your vitals, stuff like that, do a big assessment of your external determinants of health. And that should enable us to predict the diseases and conditions that you're going to get pretty well. And once you do that, you don't need insurance anymore. Like, why would I insure myself against Parkinson's if I know I'm not going to get it? So that's sort of phase one, this conditions timeline, which is this projection of when you might get stuff. The second element then prices that out. And this is where the direct-to-consumer pricing comes. So we would outline these clinical protocols, which basically say they match up with what you want, instead of saying, well, this is what your insurance would pay for the fact that you have back pain, like we were just discussing before I started in. You might say, I want to do acupuncture. I want to try this therapy that, gives me the right mapping of Pilates and yoga to deal with my back pain. I don't want injections. I don't want to have surgery. And it maps these protocols based on what you want for your care. Then we put prices on it. And, going back to this notion that there are all these different payers, each of them have a different price. We know Medicare underpays providers, insurers are overpaying to subsidize it. No, none of these numbers are real. I'd like there to be one number. And when you're in the outpatient environment, you can have one number because we can figure out what that is. And this has been the great part of, like I said, working in the ambulatory surgery center environment. Probably know more about ASCs than you want to know. But the interesting thing is, an ambulatory surgery center, like a freestanding place where you go have outpatient surgery, is a freestanding legal entity. It's separate from a hospital. So a hospital can have ownership in it, but it is a freestanding unit. So you do not have all of the overhead associated with the hospital. You don't have any of those costs. You don't have any system costs in the ASC financial model. So you can actually say, this is literally how much a knee replacement costs. And I'm sure you guys have talked about, pioneers like the Oklahoma Surgery Center, where all they do is they don't take insurance. They just take cash. And they have, medical tourism, because it's so much cheaper to have your surgery there. And even Walmart now is starting to fly people around the country to get surgical procedures because it's cheaper than it is to contract it locally for some of their members or some of the people that work at Walmart. So this direct-to-consumer pricing would be what would get mapped to whatever these clinical protocols are for you. And then there'd be this investment strategy. And obviously we're going to, we'd get people when they're young in their 20s and say, all right, here's how much you need to save. Here's how much you're going to need sort of in liquid cash for things that are going to happen this year or next year, but you need to be saving X, Y, Z over the course of your life. And then that would pop out with this report And all this would get updated annually. So you'd go back every year, you don't need to update your genetics, but what would get updated is if there are new tests, if there are tests that have better efficacy, we can improve what these projections are. If you've gained weight, we take that into account. If you've moved, this externalities assessment, if you got divorced, these are very traumatic. If somebody died, issues in your life, all of that affects what's happening with you. And then, we sort of re-up the system. And I think that, this dynamic engagement, this is one of the beauties of direct primary care. It's sort of, this is like direct primary care on steroids with the whole financial side, like basically deconstructing the whole system. So this was the big idea. I actually tried to go to market with this and pitched it to an investor here in Austin. And, the market's not ready. It's just, you can't sell this to an employer. And obviously the biggest challenge is that, well, first of all, people won't believe it works because they're afraid of change in the healthcare system. But it's this notion of getting these prices. And, that's one of the things that all of us are really gung-ho about doing. And we're getting, it's just amazing the progress that's being made on getting these direct-to-consumer prices. And we can only, improve that. So that's sort of background on that. So instead of going to market with everything, I just realized that I can't boil the ocean. And so what we're doing is we are going with this preventive care, sort of the spearhead front end to try and engage people. So we know preventive care is the cheapest, most effective way to improve health outcomes. And this is the real tragedy. People don't use it. So our platform basically has 6 modules. It's completely private. We don't contract with insurers. In fact, I never want to do that. I never say never, but like, it's not part of our branding. We don't need to do it. I don't want to share information with insurers. The whole idea is that we're outside the system. So I think I really stumbled. I struggled, not stumbled. I struggled with how to take the big idea to market because primary care visits are covered, right? I mean, they're free. And, that's baked into the ACA. Pretty much before that, it was like a $20 copay to go see your doctor. And in my book, and early advocacy stuff, I always said, I think we should make primary care visits mandatory because they're so important and people don't use them. And as I thought more and more about this and looked at how people were spending their money, especially with health savings accounts and high deductible health plans, people are looking to spend their money where they find value. And it may be duplicative. I mean, if you think that people are doing genetic testing, they're dropping $200 to do it because they're curious. A lot of direct primary care is not covered. People do it anyway. I mean, I myself have gone out of the system and done stuff just because it's more convenient. And the fact of the matter is that for decades, like my generation grew up hearing as a consultant, like, this is how it works. Economists say because it's free, people will use it. Well, they don't use it. And so for us to sort of force people to use a system that's broken, that's a real opportunity. So that was sort of my aha moment in saying, you know what, we are going to take this preventive care concept, which has been floating out there, underutilized, and we're going to package it and modernize it and sell it directly to consumers. So that's what we're doing. I think it's critical to know that when you think of going to your primary care doctor, a lot of it is just this quote unquote healthcare. I mean, this pie chart has sort of the industry accepted percentages on what are the factors that determine your health outcomes. I think genetics is probably more like 25%. Behavior is the biggest because you can have your genetic predispositions, but it's your behavior that will either amplify or qualify a lot of these markers. And so behavior is so essential. You can't control your genes. You can control, obviously with your behavior, what happens. You can kind of sort of control socioeconomic. I mean, the problem is if you start behind, you sort of stay behind, and that is tough. But quite honestly, my market is not Medicaid. It is not Medicare. I'm going for, half of Americans who have private insurance. And so looking at their behavior, their genetics is really what's going to help them get healthier. So this is kind of what it looks like. And I'm almost done. I'm, ready, excited to take questions. I've got a couple of other things in here, but basically it's an app. It's called Know Thyself. And what we've done is we're doing a lot of gamification. Basically, I spend my time doing healthcare research. I mean, if you read my book, you'll know that. And I love it. And I sort of have, I feel like some of this stuff is really obvious. It's not. But what is interesting is the more I've started to collect information about preventive care and these, indicators that are out there, and the data is free. I just know where to look for it because I've been doing it for so long. The way that the healthcare system communicates to patients is very clinical. It's very black and white, and people are not absorbing this information, and that's a failure on the part of both sides. We are in a completely different world now. People communicate with graphics. They communicate. They want to see things fast. They want to see them visually, and they want context. They don't want just a number. So we are addressing that need and pulling together all this information from people with the longer term intention of building their trust so we can get to this, sort of decentralized model. So it's a subscription. It's basically $200, which is, I went to a primary care clinic. It was $125. And by the time I walked out of there, it was about $200. And that was just to get my ear checked. And I don't have health insurance, just, I'm completely walking the talk. This is my second year. I have a catastrophic plan. So, I go get my mammographies, I go do all that stuff that I'm supposed to do, but it is, I am in the thick of it when you're talking about negotiating for pricing and asking for pricing, because I feel like, somebody's got to do it, and I need to understand what it's like for consumers. So this is sort of the deal. We've priced it at about $200 because that's what a 23andMe test is. And it provides all this cool stuff. So these are sort of the 6 areas that we're talking about. And I'll go through each of these. And then I got a couple more slides, and then I'm happy to answer some questions. So the first thing we ask is, and basically how it works is you answer 3 or 4 questions, and then a graphic comes up. And it's very, very graphically driven. So big picture is, it's basically your life expectancy. And so we've got this titrated by your race, sex. I mean, it's amazing. It's interesting that people say that everybody needs equal healthcare access, and nothing could be less true. We all need healthcare, but what we need is not equal. And that is, from your race and sex and age right out of the gate, everything changes. So especially with something like cancer, it's fascinating. So we tell people sort of what their life expectancy is, how many more years they have to live, but then they get the option to compare themselves to people of different races, men or women, average Americans, and we're giving them the average for them. So for me, it would be a white female of my age. And then I'd be able to compare myself to, different constituencies just to kind of know. We also give people the option to compare to a significant other. And the reason this is important is we're trying to give people a bigger understanding of what's happening. So if you're married and you're a male and you have a spouse who's 5 years younger than you, odds are she's going to have a longer life expectancy than you to start off with. She's younger. Odds are you're going to die. She's going to be left. How long, it gets you to start thinking about how much money needs to get saved, what's going to happen later, because, we're not talking about that. So as part of big picture, we also have an element of your financial responsibilities. And this is based on the fact that, by age 65, the average American male is supposed to save about somewhere between $135,000 to $150,000. And the average female is supposed to save more. So we just tell people, here's what you're supposed to be saving every month based on your age, just to let them know. Because again, this is not stuff people are talking about, but it's important for us to start communicating this information. Your digits is 3 areas that, 3 metrics that people get all the time without any context. One, it's BMI, your body mass index. your cholesterol level, and your blood pressure. So, I mean, the next time you go to the doctor or you go to the dentist, seems like everybody's taking my blood pressure. They just tell me what it is. And they don't say whether it's high or low. They don't say it's good or bad. And I mean, I'm in this industry. I hear the numbers and I still don't know. They just tell, I mean, there's no context. And you may hear, oh, your BMI, you know, you're obese or you're overweight. Well, how far off am I? Like, you know, how does that compare? So for each of these statistics, we have a graphic, and I'll show you the graphic for BMI next. But then we allow people, again, to compare to people of the opposite sex, of different races. I mean, it is fascinating how all that breaks out, just to give people some idea of where they are. Same thing for cholesterol, same thing for blood pressure. So that's sort of where we are. And the intent is to say how far off you are. I mean, you may only be 10 pounds off from getting to a healthy weight. You just may sort of lose hope because you don't have any idea. Your body on drugs, we ask people what meds they're on. And I should say that all of this is self-entered. We're not connected to EMRs. We're not connected to, you know, pharmacies, any of that sort of stuff. That connectivity is too expensive to do. And, you know, we are all about personal accountability. If you want to lie on this thing, you're not going to get the benefits out of it. This is the, you know, why it's private. I mean, I have no reason to sell this information to anybody else. That is not our business model. But I think we have a drug utilization problem in America, and we take all these meds. We take many more drugs than our citizens take many more drugs than other citizens do in other countries. And so what this does is it shows you a body. And if you're like an overweight woman, then the silhouette is an overweight woman. And it shows all the organs. And then it sort of, you can hover over the organs that light up, and it tells you, you know, you're on 3 meds that are affecting your brain. And it's just another way to talk about what's going on with this stuff, because all of this long-term drug use is a real precursor to dementia. And, you know, it's just, we don't talk about that enough. So that's sort of the reason behind that. Family genes, obviously, you know, we're all fired up about genetic testing, but, you know, we know a lot of this stuff because it comes straight from our family genes. This image is super cool because if you've ever done one of these intake forms, and in the work that I've done, I cannot tell you how many of these intake forms I've seen at the doctor that you filled out that are like mimeographed. It's insane. And you check off like, you know, my mother, father had blank, 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 you know, and you've done it a million times. When you do it here, you check it off. And as you're doing it, it starts to form like a DNA strand. It's just a way more gamified, it makes that connection of this is what my parents have and this is my DNA. So it's basically saying this is why we're collecting this information and this is who you are. So, and then it, you know, sort of tells us what your, you know, potential is to develop stuff. Rocket science, I talked about that. That's, you know, assesses your diet, your sleep, and then your exercise patterns. And then the big C, and it's interesting, as I was doing research, I found some fascinating data on this. And it's just so interesting if you think that, you know, cancer doesn't discriminate, but cancer kind of does, because the incidence for different types of cancer totally vary by your race, and even by your sex. You know, like lung cancer, I think is highest in white women, but it's highest in Black males. Different types of cancer. So it's really, really interesting. And there are maybe 1 or 2 additional questions we can ask people to really titrate their risk for certain types of cancers. So at the end of all this, what the output is sort of a word cloud. So I don't know if you're familiar with that, but you may have seen them on social media and stuff. And it's basically like the biggest words would be the diseases that people are most likely to get, and they hover over them and click on them, and we explain why. And then, of course, at the end, there's recommendations about what people can do. Our whole view is we're just trying to educate people. We are taking the whole educational component and giving it to people directly. We're not diagnostic. I'm not telling people to go, get this prescription or get off any meds. That's a doctor's issue, 1,000%. And we encourage people to share this with their primary care doctors, with, whomever they like. And for us, obviously, this is is going to be how we're going to go to market and potentially evolve this product, because this should be like a primary care doctor's dream. This just quickly is what sort of the BMI looks like. We have a spectrum of what, what body types are, and then we literally show people what they are. In the app that we're developing, it actually lights up a little more. We're going to have men and women. This obviously looks like a white woman. We're going to try and really make them a little more, to start out racially neutral. But then we really want to get, specific to the different types of races and sexes, just so people feel like it's much more personalized. So last slide here, like I said, we're not targeting to the Medicare audience. We're targeting towards millennials and Gen X, basically because they have enough time to make change themselves. I think probably the millennials are the biggest, everyone's targeting the millennials, but they are tracking to be the most obese nation in history. I don't think they even realize it. There's this notion of sort of this normalization of being overweight in America. And there's some interesting charts in my book about it. I've got a whole podcast about it, where basically what's happened is, when you look around, because so many people are overweight, it is normal. And over time, Gallup has done some polling, and people are getting more and more overweight and obese, but they think that that they're not. So fewer and fewer people think that they're overweight, yet more and more of them are. And that's a function of this comparative notion of what's normal versus what's healthy. And the millennials are right smack in the middle of that, because they're, growing up around, people who are heavier, and it's a real problem. So we want to get to them early to, get the right habits in and really communicate how to be healthier. So this is how to reach me. I am going to unshare now. And again, thank you so much for the opportunity to talk about this. I'm obviously really excited about this and would love to respond to any questions.
Fantastic. Well, I have to say that was quite good. And it's nice to see that you're out there, and, everybody's trying to work at these problem with different solutions, but you know what? All of them somehow start to fit together after a bit.
Yep.
So it is exciting to see. And I see we've got hands up already, not surprisingly. So let's start out with David here real quick.
Thank you, Jeff. Janis, what does your app have to offer for pre-baby boomers? And I'm not ready to throw in the towel, so I practice, we're involved in cash basis healthcare, and very much on the side of preventive medicine. And I think it's very applicable to our age group.
Yeah. So what do you mean? So basically, we're probably going to cut off, I don't know how else to say it, but if you're 65 or older, because you're on Medicare, the complexity of what happens to you is sort of, I think, inappropriate to try and deal with through an app. So pre-baby boomer is not going to be on Medicare. That's going to be my generation, Gen X. And we're targeting that group. In fact, one of the things that I had contemplated doing when trying to bring this big concept to market was doing an assessment specifically for pre-baby boomers, because I think, and this may be how we package this as this product evolves. I think that there's a huge opportunity for folks who are about to go on Medicare to understand their health better and do their best to sort of correct some of the issues they have before they go on Medicare. And I say this because I've been a lifetime runner, and I've been in my neighborhood for over 20 years. So, I mean, I know a lot of people, and there's this one guy, John, who's been running forever. He's in his late 60s, and he started having some problems and running. And, we were just talking and I said, oh, you're so healthy. You must not be on any medications. And he said, oh no, I'm on this blood pressure control medication. And I said, well, how long have you been on that? And he said, well, 30 years. And I'm thinking, a lot has happened in 30 years. You're a runner, you're in incredible shape. Have you thought about, have you talked to someone about getting off of that? Or maybe, having a different clinical approach to this, because, you shouldn't be on meds like that. To me anyway, the chemistry of it all sort of freaks me out. So to answer your question, the app is targeted towards anyone who's not quite yet on Medicare. And I think it's going to behoove us to really, as we start to roll this out, we may be able to make some of the modules more specific and ask different questions for certain age groups, because I think that's going to be important. I don't know if that answered your question or not.
That was good. Charles, I see you've got your hand up.
Thanks, Jeff and Janis. Fantastic presentation.
Thank you.
And as a longtime lobbyist before my healthcare world, and I took a break to teach social studies, tell me how you found that Walt Whitman book from the 1860s. Is it readable? Is it useful? Did you incorporate some of it in your own book? I got to hear about that more.
Yeah, so it's this was when I had a subscription to the New York Times. I sort of every 7 years, I switched newspaper subscriptions, but it was on the cover of the Times. And, it was like, oh, just recently found Walt Whitman manuscript. And so it just sounded so interesting. And so I just bought the book. It's readable because it's Whitman, right? I mean, it's one of America's greatest authors, but poets. And, but it is weird too. Because some of the things in there are just kind of kooky, but then some of the things are really spot on. He has a lot of commentary sort of railing on people who work in offices, because he just sort of thinks that, if you go in and sit down all day, that you're sort of missing the point. I mean, if, we're having that problem right now, is that, we have such sedentary lifestyles. So I don't think, so it's funny to read it knowing that it was written 160 years ago and he's kind of nailed most of the problems, but it's interesting to then look at it from today. So to answer the element of how much of that was in my book, it was more this civic responsibility for health idea that, there's so much that we can do and we should be doing that really hit home for me. And it's just, it's a goofy read. And there's drawings in it too, which are funny. You can get it on Amazon, by the way.
Very good. It was pretty cute. Any other questions we've got here for tonight? We got just time for a little bit more.
Jeff,
yes.
If Bob Stauble wants to kind of comment from his own experience on what he thinks about this Know Thyself app, that would be interesting from perspective.
Sure.
Is Bob available?
I may be. Are you there, Bob? I've got you unmuted.
I'm here.
What did you think of the presentation, Bob?
It was great. Janis, you have some really deep insights. I am kind of I don't know if you should call it turncoat, but I started with thinking that personal accountability and personal responsibility was the key, and now I've gone off in other directions.
Mm-hmm.
But I liked your idea of that kind of bell-shaped curve where there's we call them in the wellness industry the worried well.
Right.
They're the ones who sign up for the wellness promotion. It doesn't help a company's healthcare costs, but if 25% of a company are the worried well and they do Fitbit competitions and Biggest Loser challenges and they get they have more fun and consider their employer an employer of choice, there is a indirect return on investment of that, but there's no claims cost reduction because they weren't spending any money.
Right, and they were ready to do it. That's
right. And if you didn't have a wellness program, they would have found their own through an app like yours, right?
Mm-hmm.
So these traditional wellness companies, by the way, are part of a red ocean of a sinking ship because the CFOs have discovered that there is no financial ROI on corporate wellness programs.
Yeah, you're singing to the choir on that one.
Yeah. So, but then on the other side, you were saying there are people who are doing all they can behaviorally, and they're just either genetically or, their metabolism or their musculoskeletal system got too far gone, and they really have a precondition, a pre-existing condition that needs help, And then there's this middle ground that really needs some kind of the right blend of carrots and sticks, so
Right.
that, that kind of thing. But that's what's touchy,
Right.
And so anyway, I think the thing you need, the missing link, would be some kind of breakthrough behavioral change psychology isn't out there yet. Because just telling people you need more willpower, you need to,
Mm-hmm.
change, it hasn't worked. Have you heard of the book? What's the title? Change or Die, or I'm trying to think. It's a parody name, and the personal responsibility movement that people just need to take more responsibility.
Right.
Is
limited.
Is off. Yeah, it's way off.
Limited. Right.
Yeah. So helping people who want to become more accountable is awesome, but trying to kind of fat shame or wellness shame people into, you need more willpower is
It doesn't work either.
It's a failed experiment. It was a good idea, but it's a failed experiment. So anyway, I think there's some missing links in your concept, but I think it has legs, and maybe we can talk offline. I have some ideas of maybe bridging some of those gaps. So, but anyway, you're on the right track. Keep up the good work.
Yeah, I appreciate that. I would like to respond because I think that I always say this: technology is not going to change healthcare. Behavior is. And we have a cultural problem, and we basically have a generational shift that has to happen in healthcare. And, I know people really want to impact the Medicare system, but to me, that is such a problem, and it is so intractable, and it is so ingrained in the political system that there's literally nothing we can do about it. I mean, I just don't think that you can't move that boat. I also am not naive enough to think that everybody's going to care, right? They don't. And you can tell them all day long this stuff, they don't care. But I have to try, and we have to try and get as many people as healthy as they can be, and at least start trying to peel back those folks in the middle and shift as many of them out as we can. And I don't even want to call this wellness. This is education, because I think wellness has a connotation that is basically all the things you sort of talked about. But this is another reason why it's private. Your employer doesn't get this information. We're trying to give this to people. And obviously the people who are going to buy it at the beginning are going to be the worried well. But hopefully, especially with some of these images and stuff, they'll start to share it. Because really, I think when you're talking about a behavioral change, it's got to be this sort of bottoms up cultural phenomenon. Which is, that's the last thing investors want to hear when I'm telling them, because you can't control that, but it's just a fact. And this is certainly different, and it's a positive thing, and it's just one piece of the puzzle. So let's connect offline, because I'd love to talk more.
And that's so accurate, unfortunately, in all of these things we've been engaged in. It always kind of comes down to everybody taking responsibility to make the needle move. There's no legislation, no anything. It just has to happen. The key is how to figure out how to motivate the person, or make it become low-hanging fruit, or give them some incentive or something to get going. And then usually it starts to take hold. We got time for a last couple quick questions. I see, Jeff, you've got your hand up there.
So Janis, have you pretty much thrown in the towel for trying to get any kind of private equity group to take interest in what you're doing based on what you just said?
Just the opposite. So we are going to start fundraising. So,
Well, how are you going to? What's your strategy for that?
Beg everybody. So, I have, we're going to start in Austin. The whole fundraising thing is a whole other story. And I'm not quite sure the structure of your question. And I don't need to bore everybody with fundraising, but we are a pre-revenue company, so it's not a public, I can't send this stuff out on Twitter. But we have got to find a strategic investor who loves what we're doing, and raise the money to build out the app. And, once we get through this phase, that I was talking about with the developers doing what they're doing, we're going to have to do some sort of focus group with maybe an employer who could offer it as a benefit to their employees. That's one way to sell it. Or with, just a group of millennials to get feedback, to say to investors, people really like this. We're just not making this up. We have to show to investors that there's some traction for this. And, then it's just off to the races.
Okay, Charles, I got time for you to squeeze one in here, and then we're going to conclude for today and thank Janis.
Sure. We'll be quick with this. Janis, speaking of incentives to, get well and be well, what about your other foray into health savings accounts, financially incenting people to shop around or save on health care? And while you do that, Jeff, at this time, I wanted Paul Roberts, our documentarian, to talk about, what prevention, how prevention played a role in what he found around the country in terms of that part of healthcare reform, if there's time.
Okay, that's a good conclusion. So sure, Janis, why don't you answer that first part there?
Okay, yeah. So I talked earlier about how I had pitched the whole giant concept to an investor, and realized that I couldn't boil the ocean, so I went smaller. And then literally on Halloween, I pitched the idea that we would be a health savings account to an investor, which was a great conversation. And I learned a ton about how consumers spend their money. And I think that the realization that I came to in, we did a whole survey of people who had HSAs, and talking to investors who've invested in HSAs. I talked to 3 HSA companies about white labeling their HSA and how people use the information, is that I think that there's a disconnect between this idea that we're going to give people this money and they're going to know what to do with it. So, it's like, oh, let's consumerize healthcare and shift, have these high deductible health plans. And then we've got this awesome tax vehicle and an HSA. But, what happened was a large portion of people who have these HSAs use them strictly as a retirement investment vehicle. I have, a friend of mine is like, my kid needs braces, but I can afford the braces and I can afford to maximize my HSA. So why would I take the money out of the HSA to pay for the braces? Because then I'm losing basically 30 years of the investment value of that money. Doesn't make any sense. So a lot of people aren't even using it to get those tax advantages. The other problem that came out is that people were avoiding spending it. So the Trump administration last year actually had to require companies that were offering high deductible health plans, they had to include diabetes medication as a covered benefit, because diabetics weren't getting their insulin with the HSA. So it was sort of like counterproductive. It was like, okay, if the idea is that you're spending whatever, $100 a month on this whatever medication, wouldn't you like to not spend that? Hey, if you get healthier, you don't have to spend that money. That's just too sophisticated of a loop for most people to make. So they just weren't doing it. And then that made them less healthy. The problem with the HSA and then trying to work with people and have this positive loop that didn't work for us is there wasn't enough money in the HSA accounts to be enough of a carrot for people. Either they were on one end where they couldn't afford to put anything in there, or they were wealthy enough that they put it in and they didn't want to touch it. So I think that this is just one of those challenges around using an HSA to try and get people to better manage their health. The way it worked for us, the numbers just weren't there the way we were going to try and structure things, which is too bad because there's so many awesome attributes of an HSA, and I'm hoping that people get more educated about them.
Paul, if you'd like to add some closing
Yeah,
comments, would be great.
yeah, sure. Yeah, I just want to. It's really more of a comment than a question, but I'm really interested in how you're integrating the health and the financial aspects together. It complements actually my healthcare plan that I've been developing, which essentially focuses more on prevention and risk prediction. You have the genetic input, so do I, for risk prediction and prevention, focus. So some interesting parallels, and it was more of an observation than a question, I suppose.
What's your company?
Well, it's a consulting firm. It's Roberts Consulting.
Okay.
Yeah, it's a medical case management company.
Yeah, I think we're
I'm
all,
also doing a documentary as well. So kind of two different things, but they're integrated, I guess you could
cool.
say.
Like everybody in this space, you have to be working at 4 or 5 angles because that's what it's going to take. So that's really good. And I can't wait to see who we've got in the coming weeks in the same boat there with all these different hats going on. But Janis, this was great. And obviously we're all very thankful that you're making this happen, and we're all supporting you. And there's going to be more of all of us getting together again in the future. So thanks so much for being here today.
Oh, my pleasure. This was great. And I look forward to keeping in touch and all of us moving this forward together.